Atypical atrial flutters are complex cardiac arrhythmias, often involve re-entrant circuits related to atrial scarring and areas of slow communication. They may arise from the right as well as left atrial chamber. Differently from the typical atrial flutter, where the electrical wavefront revolved around the cavotricuspidal isthmus, and key to diagnosis atypical atrial flutters is the reconstruction of the re-entry caused by mapping and clear identification of the area critical the re-entrant circuit. Catheter ablation has emerged as a potentially definitive treatment options for palpitations, heart failure, and even sudden cardiac death. However, successful ablation of atrial flutter depends on the exact identification of the responsible re-entry circuit and the critical isthmus. We give the floor to dear Professor Ayan Abdrahmanov.
Dear colleagues, I welcome you here today. In this presentation, I would like to focus on peculiarities of postincisional atypical atrial flutter ablation in patients with heart failure with reduced ejection fraction. We have nothing to declare. With the introduction of never mapping system, it was become clear that in patients who have undergone cardiac surgery or extensive catheter ablation for the treatment of AF may occur non-cavotricuspid isthmus dependent re-entrant circuit, atypical atrial flutter. These tachycardias after atrial incisions represent frequent and serious problem both for identifying arrhythmia generating mechanism and for their successful ablation. Atypical atrial flutter after catheter ablation occurs in 10 to 30%, and after cardiac surgery occurs in about 10%. Significant progress of cardiovascular surgery leads to the development of substrate for atypical atrial flutter onset. Incisions after cardiac surgery are common substrate for macro re-entrant tachycardia, and one patient can suffer from several macro re-entrant tachycardia mechanisms. Mapping and ablation procedure is significantly more difficult in patients with chronic heart failure, needs complex therapy and associated with proper prognosis. The aim of our study was management, evaluation and ablation features of postincisional atypical atrial flutter in heart failure reduced ejection fraction patients. In total, 211 patients were included in the study. There were prospective group 110 patients and retrospective group 101 patients with atypical atrial flutter and heart failure. Study design. As you can see in this slide, we compared two groups of patients with atypical atrial flutter with heart failure. In the first group was performed standard catheter ablation, non-ablation index group, and in the second with using ablation index and intracardiac echo, ablation index group. Outcomes were checked in 1 year follow-up period. An electrophysiological study of the heart was performed using the CARTOS-3 navigation system. Procedure was performed with the help of pentaray high-density mapping diagnostic catheter, standard 10-pole diagnostic catheter, and Thermacool Smart Touch ablation catheter. Additionally, we use intracardiac echocardiography and intraoperative measurement of pressure in the left atrium. According to baseline characteristic of patients, our two groups of patients were comparable by the age, gender, BMI, and contaminant comorbidities. Number of previous intervention was presented in this slide. The number of cardiac surgery and catheter ablation were comparable in both groups. We can see that some patients had 2 cardiac surgery and more than 2 catheter ablation. Results of proportion of atypical atrial flutter showed that it determined in 68-78% of cases of atrial flutter in both groups and was more frequent. Due to parameter of transthoracic echo, main indications were statistically comparable in both groups. Heart failure with mildly reduced ejection fraction was determined in the majority of cases in both groups, 81-91%. Heart failure with reduced ejection fraction was more frequent in patients of non-ablation index group, in 90%, while was 8.4% in ablation group, but this difference was without statistical significance. 10. Parameter of ablations. Average operation time was numerically longer in case of using ablation index, but it generally this indicator statistically was comparable in both groups. But other parameters, for instance, transseptal puncture, was performed faster in ablation group, about in 5 minutes. Fluoroscopy time and radiation exposure were statistically lower in ablation index group. This can be explained by using of intracardiac echo. Number of re-entrant mechanism of in one patient ranged from 1 to 4. Mostly there was one re-entry mechanism in patients of both groups in 74-78% cases. About 17 to 24% of patients had 2 re-entry mechanisms. Situation with more than 3 re-entry mechanisms was rare, about 6 to 9% of cases. This finding clearly demonstrates the severity of performing catheter ablation in such patients. Ablation index parameters were from 404 till 506, with median 457. The number of complications after procedure was comparable in both groups, from 3 to 7% of cases when ablation complicated by tamponade. Zones of scar changes in the right and left atrium were presented in these diagrams. As you can see, in patients from ablation index group, more frequent localization of scar zone in the right atrium was in lateral wall and ostia of pulmonary vein. This can be explained by using high density mapping. In this slide we can see the mechanism of re-entry in the right and left atrium in both groups. In ablation index groups, in the right atrium more frequent was lateral localization, 41%. During 1 year follow-up, patients from ablation index group had less number of recurrent of arrhythmia and lower risk of atrial flutter recurrence. In 65 cases, atypical flutter was from the left atrium, so we performed analysis separately for these patients. In this slide we can see mapping process with the help of HD grid catheter, high density mapping diagnostic catheter. They were shown bipolar and activation mapping with HD grid, and it was the first HD mapping experience among the Commonwealth of Independent States. Hemodynamic parameters in patients with atypical atrial flutter from the left atrium were shown. The main pressure in the left atrium was 22. NT-proBNP average level was 974. According correlation analysis, we found direct strong relationship between NT-proBNP level and pressure in the left atrium and its diameter. Additionally, we identified a significant relationship of left atrium diameter with pressure in the left atrium and mean pulmonary artery pressure. Statistical methods showed that scan number, pressure in the left atrium, and NT-proBNP level can predict occurrence of atrial arrhythmias. And in conclusion, cardiac surgery with atriotomy is the main cause of atypical atrial flutter in 21%, in the right atrium in 90% in the left atrium. There are 2 or more re-entry tachycardias. A direct correlation was found between NT-proBNP cardiomarker and left atrial pressure, as well as a positive weak significant correlation of this parameter with an increase in the diameter of the left atrium. Additionally, there were positive significant correlation between the diameter of the left atrium and mean pulmonary artery pressure. The number of scar zones in the atria and the mechanism of macro re-entry tachycardias, an increase in the amount of NT-proBNP more than 125, in combination with an increase in left atrium pressure more than 15, and an increase in the mean pulmonary artery pressure more than 28, are prognostically significant signs of the development of atrial arrhythmias after cardiac surgery and catheter ablation. In patients with both typical and atypical atrial flutter after cardiac surgery and catheter ablation, an increase in the level of NT-proBNP more than 125 is a marker of development of chronic heart failure in them. The use of intracardiac echo makes it possible to reduce radiation exposure, fluoroscopy time, and eliminate the use of contrast agent, which increase the safety of radiofrequency ablation and prevents the development of contrast-induced nephropathy. Radiofrequency ablation of atypical atrial flutter using navigation system and the combination of chronic heart failure therapy in patients after cardiac surgery and catheter ablation reduce the risk of recurrence and prolongs the period of life free of atypical atrial flutter. High density mapping allows you to take more activation and bipolar points in a short time, increase the accuracy of mapping, and reduce the procedure time. Thank you for your attention.